Good morning and welcome to this meeting of the Health Scrutiny Subcommittee. A few housekeeping arrangements before we start, and apologies if my voice is a bit husky. It's nothing to worry about. Thank you for attending. Can I request that mobile telephones and other such equipment are switched to silent mode so as not to disturb the conduct of the meeting? There's no fire test planned for today. If there is an emergency evacuation, please take instruction from Town Hall staff. The assembly point is Tudor Square. May I ask each member of the committee to introduce yourselves, please?
Yeah, I'm Councillor Steve Harris, Deputy Chair of the Health Scrutiny Subcommittee.
Mary Lee, I'm a Councillor for Darnell Ward.
Kevin Oxley, Councillor for Mosmer.
Anne Woolhouse, Councillor for Bayton.
Martin Phipps, Councillor for City Ward, Green Spokesman.
Trish Edney, representing Health Watch.
Hi, I'm Jenny Skeeber from Democratic Services. Take the minutes.
Emily Stanbrook, Policy and Improvement Officer.
Sarah Bennett, Assistant Director of Legal and Governance.
Dramatic entrance, Sarah. I'm Councillor Ruth Wilson, Chair of this committee. Do we have any apologies for absence today?
Yes, Chair, we've had apologies from Councillor Gail Smith, with Councillor Woolhouse substituting, from Councillor Anne Murphy, from Lucy Davis from Health Watch, with Trish Edney substituting. Councillor Mohammed is delayed and is hoping to join the meeting later, but if she's unable to, we'll submit her apologies as well. Thank you. Councillor George Londons Hammond is substituting for Councillor Anne Murphy if he's able to attend.
Thank you. And are there any items for the exclusion of public and press?
No, Chair, not today.
Thank you. I'm to ask whether any members wish to declare an interest in any of the items of business on this agenda. Nothing. Thank you. And do we have any public questions or petitions today?
No, we don't.
Okay. Well, it seems hardly 2 minutes since we were last in this room. So thank you everyone for attending again today. I'm going to move on to item 6, which is a progress update on the relocation of the step-down service. It says on the agenda from Lightwood House, it's to Lightwood House, to Lightwood from Wainwright Crescent. This is an item that we took earlier in the year. So I would like to ask Heather and Greg to introduce yourselves. I think we've got you two on this item, is that right? Thank you.
Good morning, everyone. So my name's Greg Hackney. I'm Senior Head of Service in Sheffield Health and Social Care.
And good morning, everyone. I'm Heather Burns. I'm Deputy Director of the Mental Health Transformation Agenda within NHS Sheffield. This is mainly Greg's item. I'm just here in support as their Commissioner previously.
So hopefully you've had an opportunity to review the papers in advance of this morning. I did submit a late appendix, so please accept my apologies for that. That was following feedback from Lucy Davis from Health Watch to include demographic information about the home address of those that have accessed our step-down facility, and also ethnicity and religious beliefs that those people identify with. So to summarise, we presented at this committee back in, I think it was June actually, it feels like 5 minutes ago, and at that point we were asking for your support in order to go ahead with the relocation of our step-down facility, which was previously located at Wainwright Crescent, to the new site at Beach. Since that time, the relocation went ahead on the 5th of July, and 24 people have accessed the step-down facility. To be really clear about what the purpose of the unit is, it's a step-down facility from our acute inpatient, so hospital units for people experiencing mental illness, and it's exclusively for that purpose. So the pathway of care is for people to be transported from hospital to our step-down facility on a voluntary arrangement in order to support them as part of their mental health recovery and that transition into the community to promote their recovery and their development really, and I suppose rediscovering some of their skills in terms of looking after themselves and looking after their home and transitioning into the community setting. I'm very pleased to report that it's a very positive report of the much improved environment at Beach. Hopefully some of you here have had an opportunity to visit the site. I know there was a number of visits scheduled for last week. The improvements include ensuite facilities for all service users accessing the facility as opposed to shared facilities, and a much improved aesthetic feel to the environment as well, including access to garden areas. Some of the concerns or discussions that we had last time were around the location, particularly in relation to the home address of service users. To a certain extent, those issues are mitigated by the nature of the clinical pathway and people being transported by SHSC to and from their home or from hospital. However, you will note within the report that some residents or people accessing the unit have reported there's some difficulties in getting to the nearest bus stop because there's been a change in the bus route. We do need to consider that as we support service users to access the community locally. Aside from the hopefully the relatively vast positive feedback, there are some other considerations for us to take forward, including the addition of one extra wheelchair accessible toilet facility within the unit. We have one at the moment, but should that be out of action for any reason, we do need to address that, and that's something that we're considering within SHSC as part of our estate's plans. Hopefully you'll find the report useful and positive. My request for you today is to support the continued use of our step-down facility at Beach, but I would open that to any further questions, but hopefully I've given a reasonable summary of the paper. Thank you.
Thank you very much. Is there anything you wanted to add, Heather?
I think overall the quality improvements that Greg's described probably are understated, because I think the former facilities were acknowledged have been well past their best, and for example the sharing bathrooms, the kind of privacy issues that were presented to people staying there because the walls were quite thin. So there's been a number of service improvements that have impacted positively on people using the service, but also for staff. I think there were no staff changing facilities and shower facilities, and during the COVID pandemic obviously that became a great concern. So all of those things have improved both the quality of care but also the quality of experience for staff delivering the care there as well.
Thank you. Are there any comments or questions from members? Councillor Lee?
Yeah, I visited last week and it was impressive, I must admit. It was a really nice environment, comfortable, lots of privacy for people if they wanted to get off and be on their own. That was absolutely available. You could just go into your room or go around a corner and find somewhere to sit, so I thought that was really nice. I've never visited Wainwright Crescent, but I do pass it regularly, so I know what it looked like on the outside, and it looked a bit grim, so I imagine inside it was quite grim as well. So it is, I mean, staff are very positive, and I know when you move into a new environment, everybody's positive about it. I hope they can keep that. I think one of the things that was good, that the staff office was quite small, so I encouraged people to work outside in the day areas, and I think that was really a good positive move.
Thanks, Mary. I'd like to echo those comments. Mary and I went together to visit the site, and I think we were both really impressed with the atmosphere that had been created there. There were multiple sort of little nooks for people to go and sit in, and activity rooms. The kitchens were well equipped, weren't they? I think we were generally very impressed with what we saw. Again, I can't compare it with what you had before at Wainwright, but I understand that it was nowhere near the quality that you've got at Beach. And it's really good to hear that you've picked up some of those teething issues really early on and are already addressing them. So we didn't have any concerns, did we, seeing the site, because it seemed that anything outstanding was already being addressed. So that was really great to see. And I'd like to say as well how great it was to see the enthusiasm of the staff that we met, and how obviously thrilled they are with the move and the facilities that they're able to provide to people and the opportunities that that gives to residents using that facility. So I think overall extremely positive. Thank you. Is there anything else? Trish.
Thank you. Lucy asked me just to check about the accessibility with the bus route, and also the fact that this is further out of the city, and whether the people are getting access to the facility or choosing to go to the access with the facility from other parts of the city. Your study so far shows that they're nearly all from around that area, all the admissions, or many of the admissions.
I mean, I think that I did have a conversation with Lucy in advance of this morning's committee. I think the conclusion from the data so far is that there is no variation really, or no noticeable variation in the home location of people accessing Beach. And I wouldn't expect there to be a direct correlation either, because the pathway ought to be for people that requires additional support in order for them to move into the community. However, that is something that we do need to consider quite carefully. The difference in location is very minor. It's 3.6 miles from the previous address, but I do accept that that is 3.6 miles potentially further away, or certainly not closer to the city centre. At the point of moving to Beach, that was not such an issue in terms of the bus route actually came right past it. And at the moment, the bus route is just over a dual carriageway, which it sounds more drastic than it actually is if you've been to the site. So we are considering within SHSE how we mitigate that risk, both through staff able to support service users whilst they access physically support service users when they access the community. We will also need to consider whether or not we provide travel arrangements for service users, which we do at the moment on a needs-led basis. Whether or not we have a more blanket approach to that needs to be considered in terms of conveying people to and from their own homes, or indeed to access the local community. So that is something that we are monitoring and considering very closely.
Thank you.
Thank you very much. If there's nothing else that members want to add, the subcommittee is asked to consider whether it is assured that the service relocation has had a positive impact on Sheffield people, and whether further lines of inquiry are required. Is there anything that members would like to follow up on this item in the future?
Maybe a progress report in, I don't know, 6 months or a year's time, to see how things have progressed and how people, if people are using it just from one side of the city rather than the whole of the city. I understand why that might happen. You know, people do have choices to make, don't they, when they're leaving hospital. So maybe something like that would be good.
Okay, yeah, thanks, Mary. I think it might be an idea just to hear, receive a very brief report in a year, shall we say? It would be interesting to hear how the service has developed, and especially as the staff that Mary and I talked to were quite excited about the new possibilities for residents and staff at the new location. So it might be good to hear back about that. Always good. Hopefully that will be a good news story, and we always like those. Thank you. Are we all agreed, members? Thank you very much. And thank you, Heather and Greg, for coming along today. I think you're both staying for the next item. Okay. So item 7 on our agenda is the future model for the provision of health services for people with learning disability and autism. This is relating to Firshill Rise, and we have an update report in front of us, and I think Heather and Greg, and we've also got Richard, are you coming in on this item? And Alexis, if you'd like to introduce yourselves as well. Thank you.
So I'm Alexis Chapel, Director of Adult Health and Social Care. Hi, I'm Richard Kennedy. I'm an engagement manager at NHS South Yorkshire.
Thank you. So could we get some background to the report
Yes,
first?
certainly.
Thank you, Heather.
Thank you. Colleagues, this is a long-standing service that we are reviewing. And we're reviewing this for positive reasons, which is, so it's good to be able to come and talk to you about that. So there's been a programme called Transforming Care, which I think previously committees have had reports on when the programme first started. And that programme is a national programme which aims to give people less restrictive care closer to home in better community environments. We started the programme in Sheffield with 26 people with learning disability or additional autism in either long-stay hospitals out of city, often in locked rehabilitation settings, or in what was called the assessment treatment unit. And there were 7 people in those beds. Again, some of those people, both locked rehab and in city, had been there for a number of years. So the programme was aiming to modernise service deliveries because people recognise that hospitals are certainly not homes, and that has been one of the main sort of drivers for the programme. So Sheffield has worked really closely, and this has been a very strong partnership between what was Sheffield Clinical Commissioning Group, the local authority colleagues, and the Sheffield Health and Social Care Trust clinicians and operational managers to look at, first of all, the model for service delivery, but also secondly to embark on a programme of bringing people from out of city hospital placements, locked rehab where some people had been for 20 years, and to develop services closer to home. Part of that agenda was also to stop people going into hospital, because people were often going to hospital when situations were breaking down with them in the home environment or the residential care. And so the programme's really focused on that wraparound support from social workers, from clinicians, managing people better in the community. And consequently, the need for hospital beds has reduced dramatically. So when I say that, we started the programme with 26 people in hospital. Over the last year, we've needed to admit 2 people. And that's when they need a period of assessment treatment to stabilise their mental health condition under the Mental Health Act, or as a result of behaviour that is challenging to support. So as part of this programme, Sheffield was in a slightly odd situation in that in South Yorkshire, we were the only area that had an assessment and treatment inpatient unit. As the programme developed, Sheffield needed fewer and fewer of the beds that we commissioned en bloc from Sheffield Health and Social Care Trust. Our commissioners in South Yorkshire were using the facilities, but as they developed the programme, they didn't need the beds either. So we were left with a position where we had substantial amount of investment in, or have substantial amount of investment in inpatient beds, but actually what the programme is telling us we should be doing is invest more in community services. Now we have been able to do some investment in community services, but obviously whilst we've got the inpatient beds to this scale that we've currently commissioned them without a need for those beds, we've not been able to invest as much in community services as we would like. So what this paper is talking to you about is our thoughts and considerations around how do we enhance those community services. The Care Trust have been doing a lot of work with service users, families, experts by experience to look at what people want within a community setting and what they feel would support them better, and to look at the community services that we'd already got in place to see how we might enhance them. So, for example, currently, those community services only work Monday to Friday, 9 to 5. So if somebody goes into a crisis at the weekend or in the evening on a Friday night, you can bet your life that the worst outcome would happen for them in terms of there's limited interventions. So people will often end up maybe presenting at A&E or getting into kind of more crisis. So what we're trying to look at is how we could enhance those community services to extend the offer into evenings, over weekends, but have a much more effective wraparound service. Now, I mentioned the work that clinicians and social workers have done, and part of that work is something called care and treatment reviews. And what they do is they bring a multidisciplinary team, the person and the family together to say, what's the best way that we can enhance this situation, support this situation, and try to avoid people going into hospital. So as I said, going from a kind of inpatient average of around 17 to 18 people going into a hospital placement back in 2019, we're now looking at 2 people having needed hospital care in the last 12 months. So what the report is talking about is that community model that we feel we could enhance further, but also to highlight to committee the fact that we do have money invested in learning disability specialist hospital beds that we no longer need, and we can see that pattern has been of reduction over the last 5 years of the programme. We're at a stage where we've been thinking about the community model, as we say, doing that engagement, but we now want to embark in a period of engagement and going through into co-production engagement and then into consultation around what do we do about the future of the Firshill rise beds. Clearly, taxpayer money being spent on a resource that there is not a demand for is part of the picture. Part of that conversation has been at a regional level with our co-commissioning colleagues in Rotherham, Doncaster and Barnsley, and they are also telling us they do not have a need for that model of care, for those inpatient beds, the assessment treatment beds. So we want to go through a process where we talk to the population, people that have used those services before, people that might need to use those services in the future, to say, what are our options? What's clear is you can't run a 7 or 8 bedded unit and just open it for two admissions a year, because it really isn't effective in terms of being able to staff that service, manage it effectively, cost effectively, but also in terms of attracting staff that would be kind of there twiddling the thumbs waiting when there's no admissions. So, and we really do feel that the sort of national evidence and local evidence is that enhancing the community services further will prevent the need even more. Nevertheless, we don't want to say that people may never need admission, because treatment and care is important. So part of this consideration is what is the alternative for us? And we're talking to our colleagues now that we are an integrated care board across South Yorkshire about what that solution might be for us across South Yorkshire. But to look at having an open conversation with the public about enhancing community services as the national programme, doing it further, going further on that programme, but also considering what we do about the Firshill Rise current commissioned service. My colleague Richard can outline the kind of consultation process that would go, and the engagement process. So if I could just hand over to Richard.
Yeah, so we're very keen to start a conversation quite early in this process. We've got a number of issues and opportunities that Heather's highlighted, and we think it's now important that we get the public, and particularly people living with learning disabilities, thoughts on some of these issues. So our plan is, and we've already started an engagement process that talks about those issues, and one of the appendix of the papers has the issues paper that we're going to be using to do that. We have been we've been having conversations with a number of different community groups about providing grants to them to help us with that engagement, recognising that they have unique skills in advocating for people with learning disabilities, and we really want to draw upon their skills and their contacts to to have those conversations. So MENCAP and Sheffield Voices, part of Disability Sheffield, and Burton Street Foundation, we're working with them, and that's very much on a basis of them telling us what's the best way to engage with the cohort of people, and we're very flexible with how they do that. It's been a success of our approach within the NHS in Sheffield for a couple of years now, in really listening to the voice of community organisations in how they work with their own communities. So it's one that we're keen to carry on and support with funding to do that. So once we've done that, which we expect to kind of be towards the start or mid-January, by the time we finish that process, we will then move into a period of options appraisal. So at the moment, you know, we know that there's lots of different avenues that this could potentially go down, and we want to include that information and the insight that we gather from this first stage of engagement to really influence what those options might be. And we hope that we'll also be including experts by experience, people living with a learning disability, their carers and families, in some way in that options appraisal as well, so they can have a direct influence on what are the most important factors that we consider when we come to actually whittle down those options into something final. Then we will may at that point, depending on what the options tell us, need to go to a formal public consultation. We'll obviously come back to this committee for you to have your input into that as well, and get some of your steer from on your point of view on those. But we are committed that if required, we will go to a formal public consultation on whatever options have been highlighted as a potential way forward. And we hope that there will be more than one option at that point, although we'll see how that goes. Then we hope that kind of want to be slightly loose on the timescales, the exact timescales. We have a time frame put out at the moment, looking at hopefully a decision around May, following consultation. But I think pragmatically we might have to move that depending on what comes out of the engagement and the options. So I think we have to remain flexible with that, but we would like to keep to that if possible.
The other thing just to add is I mentioned that we are working with our Integrated Care Board partners across South Yorkshire, and Alexis, we've lived some of these experiences over the last few years, where we feel sometimes we have some missing parts of the offer to people, and particularly we're looking at what we would describe as a step-up facility. Now, that would be to avoid when a situation's completely broken down at home, but we can't find a provider that will say, okay, we'll take this person on who's in crisis. The step-up beds, we're talking such small numbers for the city, it's likely that that will need to be on a South Yorkshire footprint. So we're working with our partners across Rotherham, Doncaster, Barnsley to identify that kind of facility. And by step up, we mean somewhere where you can have a period of decompression, intervention and de-escalation of the situation that you're facing, in order to then go back quickly to your home environment. What will typically happen, despite all of the work that clinicians and social workers do to avoid hospital admission, eventually people end up sort of with no options, and so sometimes get admitted when that situation's broken down irrevocably. I couldn't say that then. So the idea is that we'll look at a step-up facility across the South Yorkshire area for those small number of people where we really can't stabilise them in the home environment, but they definitely don't need hospital care and they wouldn't be admitted under the Mental Health Act. So that's a piece of work that we're doing with our ICB colleagues, but also local authority colleagues, looking at the specification, etc. And then there's other pieces of work that local authority colleagues are doing. I don't know whether you want me to cover or do you want to cover?
Yeah. Maybe just to add into here is one of the key things for me, so like a couple of years ago, coming to post, was how do we focus on prevention of admission to hospital rather than discharge from hospital? Because the question is always, how are we discharging people? And to me, that's the wrong question. It's about how are we enabling people to live independently at home and live in the life that they want to live. That's the starting point. And so to that end, over the last couple of years, we've really worked jointly together to think about how we make that a reality. And there has been a lot of close working between each of our three organisations to go and do that. And I think that's been really tantamount to a lot of the good conversations that we've had. And on a very practical basis, what we've done is align some of our programmes of work. So within adult social care, the Adult Social Care Policy Committee has approved the recommissioning of supports to working age adults, and that's currently underway. And what that really does is supports the work that's going on here, because actually what that starts to dovetail is the supports that adult social care providing alongside health services. And what we've done is really much has had each of the teams involved in each of the different exercises. So what we're doing is we're working together in a way and in partnership with people in a way that means we've got joined up support. Because ultimately, you know, from a point of view of individuals, what they're seeking from health and social care services is that very much that joined up support that is seamless from the point of view of the individual. So actually a lot of the work that we've done now is really discovered now to a good kind of point of joined up fruition. The other key aspect is around the future design of adult social care, which was also approved at committee. And the key principle of that is about how do we support people to live independently at home, and to really support that earlier intervention, to support that short-term target support, but also to support people to live that life that they want to go and live. And all the kind of different, the change towards moving from a generic sort of type of social work to that of more specialist adults with a disability service, and particularly a focus on having the views of people with disability at the heart of that, is absolutely core to how we take that forward. And a lot of that absolutely dovetails with what's going on here. And certainly for me, I'm going to say this it's really lovely to see, and I think the journey that was happening with Firshill Rise from a couple of years ago to where it is now, where it was to where it's now, was really talking about a community offer that actually enables people to be preventative from a far more robust community offer, but also secondly the offer of a step up, you know, facility. That's really what people have said time and time again. We want to see it rather than having people staying in hospital for long periods of time. So that's the assurances I could give that we are dovetailed with our activities, working really joined up way across health and social care, and our teams have worked closely together to go and do that, which is really what we want to be able to say, so that from a point of view of people, it's joined up seamless support.
Thank you.
That's the crux.
The other thing to draw your attention to is what we have found particularly over the pandemic and post-pandemic period, is that whilst the presentation of people with learning disability and autism has reduced in terms of that need for hospital care, we have had an increase in people with autism only, without a learning disability, presenting in crisis. Now, Firshill Rise was never designed for that population, and you would not mix people with an intellectual impairment with those that don't have, just because they've got features of autism. So we're not talking about Firshill Rise being this being the only piece of work that we're working on, because we're also looking at the needs of people with autism as well when they present. Now, largely those people should be able to be cared for within a mainstream acute mental health hospital placement, but there are very, very small number of people, 1 or 2 people, where actually we feel they may need something differently. So we need to think about that population. But in terms of Firshill Rise, that was never designed for that population, and it's an emerging trend that we've noticed over pandemic, people going into crisis. So part of this overall work as well will be looking at how we can improve the offer, particularly in community services for people with autism too. And we're just investing in what we describe as an autism crisis nurse that can work a bit more effectively when people are admitted to mainstream acute hospital. But it was just a feature I wanted to pull out, because people can get confused between when you're talking about learning disability and autism as opposed to learning somebody with autism without learning disability, and it's 2 different cohorts. But just to sort of flag that we are looking at both sets of people's needs.
Thank you very much for explaining more about that. And I guess there are some questions around this, so we'll go to members and see what they'd like to bring forward. George, welcome, George. Glad you made it.
Apologies, I was late, Chair. Thank you for this report. I think, firstly, in terms of what you've laid out in terms of the consultation and the route forward, it seems sensible. There's clearly more detail needed in the timescale, and particularly, it seems quite ambitious in terms of, particularly if public consultation was needed, in terms of that May timescale. And obviously, I think we'd all encourage this to happen right, as well as in the right timescale. But I just wonder, and so please take what I'm saying now in the context of I think I support the actions here. But what I was really surprised about and quite concerned about in this report and what's been said today is that we've heard lots of justifications why this is needed, and I don't doubt them all. We've heard, the use of taxes money and the unsuitability of the Firshill rise facility, and also the change in demand and the laudable want to go to more towards community services. But we've heard nothing about learning from or a reaction to the CQC report of last summer. And it's just, I want to understand why that hasn't been referred to at all, because that was a really, really difficult moment for the learning disability community in Sheffield, and the things that report contained were incredibly difficult reading, and it feels like the least we can do is to use that difficult experience to inform what we're going forward. And I'm just confused because there's been so many reasons, good reasons no doubt, laid out here for why this should happen, but that, frankly, tragedy of how we got there to the point of summer last year appears absent here, and I'm just confused. And I just think if this report is out there and to be read by everyone, including people that were directly and indirectly affected by what happened, and I think they will be surprised and confused that's absent, and I just wonder why that is really. Thank you.
George, I just want to say you're absolutely right, and I guess I was thinking about the future, and of course part of that thinking about the future is thinking of alternatives to what we've had in the past. And so I think that was just so inherent in some of this thinking. I didn't state it, and I should have done, so apologies for that. I think in terms of the national learning and also that local learning, it is part of why the whole Transforming Care programme was initiated, and why we have been working hard on trying to look at improved offers in the community. And I think what we're trying to embark on now is that opportunity to reflect back what did get offered in the past and move forward into what would be a better offer. But I completely take your point that I should have referenced that in the paper, and I didn't. I'm happy to amend that if that would be helpful.
Maybe I'll come in here, because I think it's a really good point by George, and I think one of the key things maybe is a helpful proposal for the Health Scrutiny Committee is, I haven't discussed with colleagues here, is that we actually take back the learning from Firshill Rise back to committee in the future, because actually there was a lot of good learning, I think, across partners. And I think the CQC, that was a very much of a turning point about how do we want to work in a very different way and going forward. And perhaps that would be a really helpful point to say, actually, as the engagement starts to happen, how do we take the learning, how we bring back the learning about what we did and what we did differently, and how we want to work differently and going forward, and particularly the reassurances that have been put in place. That might be a helpful proposal.
Yes.
Yeah, just supplementary to that, obviously I'm here representing the provider in this instance, and that there is significant learning within Sheffield Health and Social Care in order also across the wider system and indeed the region. I think that your point is very valid, and that's something that we absolutely need to consider and need to make sure that other colleagues are cited on that learning. There will be opportunities as part of the engagement with our service users, carers, families, to explore that further and also perhaps to explain that that was the catalyst for the change. I think Heather summarised very well the national, the regional and local drivers for some of this change, including, you know, transformation and also changes in demand. What we're trying to represent here is a needs-led pathway, but I think that does stem back to the learning from Firshill and that CQC inspection that you've referenced. So we absolutely need to make that abundantly clear to people. And I would suggest that the first point of call with that is to pick that up through the consultation that we have planned from now, before we move into any further options appraisal. So thank you.
Thank you, George. Any other questions? Mary?
It's not a question so much. I mean, I haven't read that CQC report. I was aware of it, but it would be good. I don't know if you've fed back to service users and people in the learning disability community, including carers, you know, give them a chance to express what they felt about it and what they feel about it going forward. I'm sure this consultation will help in that. And I mean, I know that community from a few years back, so I understand how they function and how they feel about things. I think if there's a bed there, it's an option. It's always an option to use that bed rather than develop new ways of working with an individual. And in this community, you do need to have that individual, know that individual, understand what the triggers are for their crises. And I think if you've got a specialist team, and it must be a specialist team working with in that particular group of people who are more likely to go into crisis, that's a good thing. And if you can reinvest that money in that community team, all well and good. Sometimes things get diluted as time goes by, and I just worry that might happen for that. And I think we just need to put safeguards in to make sure that doesn't happen. You know, we know money is tight, and there's a crisis in the country, and there's a crisis in healthcare. And the first thing sometimes that gets cut is hospital care for and health care for people with learning disability and people with mental health problems, because we don't immediately see the effect as we do with people who are suffering, you know, physical illness in a hospital who haven't got a bed maybe to go to. So I just think we just need to make sure we ensure we have got a good that the culture is right and that the care is top quality, and I'm sure it will be, and that we can sustain that over a period of indefinitely, and we sustain that kind of care indefinitely, because it's absolutely what is needed. I just wonder also when you do need a bed, because you will need beds for some individuals, because they can be not just in crisis, but maybe dangerous to themselves, a danger to other people. Where have you got a facility in mind? Is there somewhere now in South Yorkshire where you would transfer people to, or are you looking at developing something like that?
So I could answer the question about the quality principles. One of the key actions is actually in the Council's delivery plan, as well as in the adult social care drivers, is to develop a joint quality committee with a joint quality board with kind of colleagues in health, so that what we have is a joint oversight of all care provision across health and social care. Because that we came from basically both the duties of both the chief nurse and the ICB, and also myself as DAS for the council, because what we wanted to ensure is actually what we have is exactly what you're saying, is that as there is a drive towards further efficiencies, what we want to make sure is the principle of quality doesn't get lost and outcomes for people, because that's absolutely the core and the heart of what we've got to go and do. So that has now been set up, and one of the key things for that is we want to have experts by experience being core to telling us how services are actually working and how we're working well, particularly Sheffield Voices, who actually we fed back to as part of the work around Firshill Voice, has been really key to that. And actually one of the papers that's coming to committee over December time is about how we build up with experts by experience and co-production and involvement, so that absolutely that's core to we're driving in quality and going forward. But that's certainly an assurance I can give about the quality, you know, and a quality principle. And perhaps I'm just thinking, although it's coming to the adult committee, we could also look at perhaps as Alan and I come into a future committee for the health committee to talk about actually the development of that, how that work in practice, and to get committee members' views about how and to support that future involvement. And you know, I think certainly the learning, particularly from Firshill, but also the learning from other CQC reports that's happened across Sheffield. I think what's really brought home is what's really important is quality, and we've got to make sure we've got assurances in place that quality is being delivered right across all health and care services. So hopefully that's helpful and reassuring. And that's it, because I can work with.
And I'll come into the second question that you asked, Mary. So part of the thinking about options as we're going forward is what is the alternative? Because you're right, we will, on occasion, as I've just mentioned, we've needed 2 people to be admitted over the last year. We will need an appropriate facility. So part of this whole process is there another facility within this region that minimises travel? We would need to think about if we did use an out-of-city placement, how we might procure that and how we might quality monitor that. Part of enhancing the community services would be that we would have more clinical staff that can have eyes on if people were admitted out of city. Within NHS Sheffield, we have now a full-time clinical nurse that oversees placements and oversees when people, the sort of prevention pathway, but also if they are admitted, their quality of care once admitted and subsequently part of their discharge planning. So the thought is that having an enhanced community service with specialist clinicians that you mentioned, they would be able to be robustly overseeing the quality that's been delivered alongside social care partners and social workers. So there are systems of commissioner visits, there are systems of care program approach, which is been changed, but nonetheless is part of the kind of process for monitoring people's care. And then as well, the care and treatment reviews that I mentioned earlier, which is this multi-agency, multidisciplinary review involving families, that is part of the process for overseeing people's care.
Thank you very much, both. Anybody? Mark?
It's just a quick comment. I just wanted to say thank you for the report. I was initially going to ask about co-production and engagement plans, but I think actually you kind of answered that in your initial talk about this item. And I think you've outlined a good plan to me to start with, and I guess we'll see later how it progresses. Although I do agree with Councillor George Linderham's point around making sure that we give enough time to take feedback. So maybe the timelines need to be looked at, and it shouldn't be kind of following the pressure of the timeline but getting the right outcome. And I just wanted to kind of agree with what Alexis Chappell was saying about the aims of early intervention and prevention, and it's good to see a success in this, and that the reduction in need for as many inpatient beds. So I just wanted to kind of say that's great to see that. It's good to see a success in that. So thank you for the report.
Thank you.
Thank you. Anyone else? I've got a few questions myself, if that's all right. Just referring to, in your report, point 3.2, which talks about the need for inpatient beds having greatly diminished, and South Yorkshire was acknowledged nationally as having achieved some of the best progress in this area. I just wondered if you could outline a little bit more about what that progress actually looks like. What are the measures of progress in that context?
Yes.
Is it a measure of needs being met and patient outcomes, or is it a measure of the transformation as a more procedural thing? So yeah, what does success actually look like for patients?
Thank you. That's actually the most fundamental part of this, isn't it? What difference has this made to individuals? So first of all, I mentioned the 24 individuals that started life often having been in locked rehabilitation, so semi-secure facilities. And for those people, it's completely transformed their lives. Obviously, I won't go into patient detail, but I'm a speech therapist by background in learning disability services, and there's a person I worked with many years ago that really stayed with me for some reason. And through his life, he'd had crisis after crisis, and he did have exceedingly behaviour that was exceedingly difficult to support, because he was often scared in terms of sensory overload, and so would sometimes hurt other people and himself. At the start of this programme, he'd been in secure care for almost 20 years, I think slightly over 20 years. He's now living in residential care with 3 or 4 other people. I have to say that I was myself worried and thinking, you know, this step down has got to be so carefully managed, and it was carefully managed. And he's now been in that facility for 3 years. So in terms of an individual's experience and outcome, I think that is a really good example. And there are many other examples of people that have gone through that process and that discharge process. So outcomes for people certainly improved. Length of stay reduced, so when people have gone in, needed that treatment, that length of stay has reduced. So we started the programme sometimes with lengths of stay in excess of 2 years, even though the programme was meant to, the intervention was meant to be around a sort of 6 months maximum. We've found that we've managed to reduce the length of stay so that people are going back to residential care. So that would be another positive outcome, getting back into normal life again. And then the national programme had set a target of bed reduction, unnecessary, bed reduction across the area, and monitored us on a weekly basis. In fact, we even had scrutiny from the top level within the NHS and NHS England in kind of scrutiny calls, because we did have so many people in South Yorkshire in those out of city, not in out of city, in hospital care. So part of it was making sure that we got people being avoided, the avoided admissions and the reduction of the times that we needed those hospital beds. So all of those measures have been very carefully monitored, but also monitored in terms of the outcomes for individuals, readmission rates, because that would be seen as sometimes necessary, but an indication of failure. So readmission rates were also tracked, and they've all come down. And as you said, we were nationally acknowledged as being highest performing in the country on this agenda around South Yorkshire. And I think particularly Sheffield's journey has contributed to that. But for me, it's about individuals.
Yeah, okay, thanks, Emma. Do I take it from what I've read in the report that Firshill Rise is currently closed?
Yes,
And so does that mean there's no inpatient facility at all in South Yorkshire at the moment?
That's right. So at the moment, the people that I mentioned, we've got one person in hospital care in an out-of-city placement in this region, North region. But and that's what we need to think about in the future, as Mary was saying, what are going to be the options if we still do need beds. So we would need to think carefully about where we would place somebody. What we would not want to do is have an ad hoc arrangement where suddenly on a Friday night you need a hospital bed and you're ringing around the country to find one, because that wouldn't be a pathway. So it would be about how we might be able to secure something as an alternative if that was one of the options that emerged. We need to think about that in terms of the alternatives. These are very specialist types of provision in terms of the build, so it wouldn't be a question of saying to the care trust, can we just take a little bay from the mental health wards? They need to be built and designed in a certain way and staffed in a certain way. But that's got to be part of the consideration for the future, and when we get through that consultation, that has to be some of the issues that we put on the table to people.
Okay, thanks. So if you are looking at effectively opening a new facility somewhere in South Yorkshire, the question that you're going to ask in the consultation process or the engagement process, what are the potential issues of having learning disability crisis beds outside Sheffield? That question is just the same for the other districts of South Yorkshire. You know, replace Sheffield with Rotherham, Barnsley or Doncaster, and it's the same question. So for people in 3 out of the 4 districts, the answer is going to be something related to it's out of town. So how do you anticipate sort of managing that and making a decision on where something should be located?
Yeah.
How would the balance of views be weighed up there?
Yeah, I think that is going to really form a major part of the consultation, because it is about, first of all, quality, as you were talking earlier, the CQC ratings, the kind of, we have a system of commissioner visits anyway to some of the outer city placements across the area. So what's that telling us? What is that provider like? We'd have to have a procurement process to identify the most appropriate beds, and then a process of continual monitoring. So that will be, if that is one of the options that we start to explore with the public, I guess there's the trade-off of local versus more community services, and we would want it, the criteria would be as close as possible to Sheffield to minimise travel. And I think we would also have to think about how we'd mitigate any impact on family members around travel, and by that I mean what support we might be able to put in to help people to travel, because I think that would be important.
If I could add to that as well, the consultation is largely focused around the whole pathway for people presenting in crisis. So the majority of this focus needs to be at place. So thinking about people's locality and where they live in terms of the crisis offered to them, and also thinking about the alternative to admission. So we know from experience that a large proportion of people may not need acute inpatient settings. They may need an alternative to that, such as we've coined the phrase a safe space for now whilst we're working up this programme of work. So the consultation absolutely needs to consider, if somebody is acutely unwell and does need hospital admission, where is that and how close to that is to home. I think the bigger question for the majority of people that we're consulting with is around what's the main part of my care and where is that situated in terms of people coming to my home to see me at home or in my locality, rather than me having to not having that, and the alternative being that I am sent far away from home to a hospital.
And just to add as well, I think that for me that last question is the importance of that is to really dig into what are the important factors that people have, or what are the concerns that they have if they or a family member has to go to an out-of-city placement. Actually, what are those factors that are the really important ones? So is it about getting there to visit them, or is it about the concerns about the quality of care and the monitoring? So for me, that was a really important one to put in there to actually understand those, so we can start to prioritise when we come to the options appraisal, at actually kind of saying this is what people have told us is the most important factors for them, and therefore we need to put that high up on our marking of those options.
Is the same engagement exercise happening in the other 3 districts as well?
Not that I'm aware of. I'm only aware of that we're concentrating this on in the Sheffield place. So I'll pass over to Heather about the decision that they've made in terms of what they want to do.
So, as I mentioned, the Transforming Care programme, we have been working in partnership across South Yorkshire, but each area has its own patterns of demand and need. So our Rotherham and Doncaster colleagues were very clear that they did not want assessment treatment beds. It's a model that was, if you like, the last type of model that was initiated a number of years ago. So they've been very clear that, as we are now saying, that they don't need that kind of service offer. So they're not going through a consultation process at the moment because they don't have beds they've actually got to decommission. They'd already closed their beds a number of years ago. So they're not quite in that same place, but we are still working in partnership to look at things like the safe spaces, the step-up unit that I mentioned, to look at that around the needs that we're identifying commonly across South Yorkshire to see if we can look at that together and develop that together.
Okay, thank you. I think, Mary, you've got a question?
It's just following on from what you're saying. You need 1 or 2 beds a year for some people, some individuals. That's what Sheffield needs, and I presume there's, well, you mentioned Rotherham and Doncaster don't particularly need, but they will have people in crisis as well.
Yeah.
And Barnsley, similarly. Yeah. And when we talk about crisis, we're not talking about something that can be solved over a weekend or over a couple of weeks. We're talking about something that is longer term, aren't we? If we're going to be sending people somewhere else to deal with that crisis. I just, on that basis, where it's, I suppose I'm thinking, what will happen to Firshill? Is that in the mix, if you like, in looking for some kind of facility?
Yeah, I mean, everything is on the table still, Mary, and that's part of this process that we need to go through. So I guess what is already clear is we don't need 8 beds, because we commissioned 7, but there was an 8th bed as well. We don't need them, and it is not necessarily an effective way to deliver a service, that size unit for those few admissions.
Sorry, I was thinking would it be something you'd envision as a regional kind of service? That's what I'm getting at.
Well, the other areas have already said that they don't want to do that. Yeah. So I mean, that has been an ongoing conversation with the other areas, but they're very clear they don't want assessment treatment beds. And when we sometimes when we're talking about admission, it isn't always for that type of service. It might be more the kind of locked rehab type need. So it depends really on the presentation that somebody comes with. We're not closing that conversation though in South Yorkshire, even though they've all said they definitely don't want to co-commission assessment treatment beds. Those conversations are ongoing, and that's including the step up facility that I just mentioned.
Okay, thank you very much. Colleagues, is that all your questions on that? Thank you. So we're asked to note the issues outlined and comment on them, which we've done. Indicate any initial considerations relating to this piece of work. Note any additional considerations related to the planned co-production engagement and consultation process and timeline. And I think on that, Councillors Lindis, Hammond and Phipps both suggested that there might need to be some flexibility towards the latter end of that to allow time to weigh up some further input. I think as well we'd like to accept what Alexis suggested about bringing a report to Scrutiny in the future on learning from Firshill Rise. And I think you also suggested bringing more about assurance and quality monitoring to the Adults Committee. So I think both of those are good suggestions that we probably want to note and accept. Are there any particular issues or comments that members would like to be noted in our response? Apart from that. Okay, thank you. So, we note the report, and you've heard our comments about it at this stage, and I think we're assured that you're looking at everything that's of consideration to us. So we look forward to hearing the next stage when you come again. I think in January.
Thank you.
I think that's right, isn't it? There is just a little question mark over the back end of the timetable, I think, isn't there? And if it falls into the period around the local elections, that might just be something that has to be considered later on in the programme about the suitability of conversations at that time. I'm sure we can work around that.
Thank you.
Okay. Thank you very much indeed for your input. Okay, on to item 8 of our agenda, which is to receive the decision-making business case on the general practice transformation proposals. I'd like to welcome. I'm sorry, I can't read. I can't read all of your cards. One of them's upside down. Is that deliberate?
No, that's not. Yeah, we haven't got one.
Oh, okay, okay. I'm going to ask you all to introduce yourselves anyway. Apologies, we haven't got a card for you, Mike. So if you could just introduce yourselves and perhaps just briefly outline the role that you've had in this programme so far, so we can understand why you're here.
Shall I start and then I'll bring some up. My name's Jackie Mills. I'm the Chief Finance Officer for Sheffield within NHS South Yorkshire. My role is I'm the Senior Responsible Officer for the Sheffield schemes as part of the South Yorkshire programme. Holly?
I'm Abby Tebbs. I'm Deputy Director of Primary Care at Sheffield Place for the ICB.
Hello, my name's Alice Deasy. I'm a GP at Hall Medical Centre. I was a partner over the summer when lots of discussion was happening around the building, so I'm representing the partnership today. Thanks.
And I'm Mike Speakman. I'm the Programme Director for the Sheffield Hub schemes.
Thank you all very much for coming today, and particularly those who have been frequently, Jackie, for giving your time yet again today. So we have the decision-making business case in front of us on these Sheffield Transformational Hubs. May I just ask before we go any further, is there a definitive name for this programme? We've used GP hubs, we've used transformational hubs, we've got health centres. Is there an appropriate name that we should be giving this?
So we did refer to these as transformation hubs, but as part of thinking about how we explained it to the public, that felt too vague. And people understand the concept of health centres. So in our public communications, we've referred to them as health centres, but they're more than just buildings, which is why we've referred to the project as a whole as a transformation hubs. So I'm happy to take advice from the committee about how best to describe it, but it's about something that we want to describe to our public that makes sense to them. So that's why we've tried not to make it too complicated.
Okay, thanks, Jackie. So we've got the word hub used predominantly in the report, but we're talking about health centres where services will be co-located within primary care. Thank you. So if you'd like to present your report, thank you very much.
Thank you. And as you say, the purpose of presenting today is to present a draft of the decision-making business case in relation to the proposed developments of GP health centres in the north of the city. And this follows on from the consideration of the outcome of the 10-week consultation that we presented to this committee at the previous meeting on the 23rd of November. And following that meeting, this committee gave us comprehensive feedback on the proposals, and I'd like to thank the committee for its careful consideration and the time it's taken to provide that feedback. So the purpose of the decision-making business case is to decide on which, if any, of the health centre hub proposals go forward to the next stages. And to do this, the decision-making business case reviews the outcome of the public consultation, including the feedback from this committee, the quality impact assessments, together with learning from the 4 years of development we've undertaken to produce the outline case and the outline business case. It also aligns the other factors that have developed during the consultation process and looks to ensure that the final proposals are deliverable in service, economic and financial terms. So the draft recommendations of the business case are outlined in section 5 of this report, and those recommendations are that we move forward with 3 of the 4 hubs that we consulted on. So that would be a new hub in Burngreave, be built next door to the current site of Sheffield Medical Centre, and that would involve relocating 2 practices, the Burngreave practice and Sheffield Medical Centre, that currently operate from 4 sites. Second hub would be one located in Firvale, relocating 2 practices, that's Hall Medical Centre and Upwell Street. And finally, a third hub in Parson Cross, relocating 3 practices,
being Buchanan Road Surgery, the healthcare surgery, and Margetson Surgery, which is a branch of the Ecclesfield Group practice. And then the fourth hub that we consulted on that was proposed to be built in at Concord Leisure Centre is no longer being pursued due to the views expressed during and before the consultation. Just to highlight the factors that we've used in making the recommendations in the business case, so they are outlined in table 3 of the business case on page 18, and those factors included looking at the strategic weighting based on targeting investment into areas facing issues of deprivation, an assessment of stakeholder support, including importantly the views of this committee, an assessment of the value for money using Treasury requirements to value both the benefits and the costs of the proposals. Issues of affordability, both in terms of the capital available to us, but also in terms of ongoing running costs. An assessment of practice commitments to proceed. And it's important to note that practices have taken on board issues highlighted in the consultation, alongside their willingness and ability to proceed. And finally, an assessment of the technical ability to build on the proposed sites. Finally, I just want to note that a draft of this business case was considered yesterday by the new Sheffield Health and Care Partnership Board and is intended to be presented to our Strategic Patient Involvement, Experience and Equality Committee on the 20th of December. So views from each of these meetings will be used to inform the final decision-making business case, which is due to be presented to the NHS South Yorkshire Board on the 4th of January. So if the recommendations are approved, it is important to note that there remain a series of steps that will need to be completed before a final decision to build the hubs is made. So this will involve finalising procurement options to move to an outline business case, firming up the service model in terms of what services will be delivered, and that will be working with practices and partner organisations, as well as issues such as obtaining planning permission. So the subcommittee is asked to provide a formal response to us in advance of the presentation of the final business case. We've asked for views by the 14th of December, but do recognise we've asked you for an awful lot of information at short notice. So I'm happy to get feedback from the committee about how realistic that is as well. So happy to open it up to comments or questions.
Thank you very much, Jackie. Is there anything that anyone else would like to add at this stage?
Hi, thank you. Thanks for inviting me to be here today as part of this scrutiny. I suppose I just want to say from Page Hall Medical Centre's perspective, and also I've had a conversation very recently with one of the GP partners down at Burngreave, and we really value the scrutiny that's gone into this and the comments that have been made, and the GP practices do share quite a bit of some of the kind of the thoughts that have come out of that and out of the consultation. 2 points that I just wanted to make. One is that this needs to be financially viable for the GP surgeries. So although we see huge value potentially into moving into these, and I've heard in the last scrutiny committee meeting them talk about sustainability for partnerships and things like that, which is really important. But there is still, certainly definitely for Page Hall, there is still a question that we're in an ongoing discussion with Mike and the team about concerns over service costs and whether this, we need to make sure this is not more expensive for GP surgeries to move into, because what we don't want is a scenario where we have to reduce staff costs, for example, and the service we provide to patients by moving into a building where the service charges are higher than what we currently pay. So that's the first point I've been asked to make by the partners. And then the second point, I know has already been discussed, but I'll mention it anyway, coming from the perspective of the GP surgeries, is just about the issues of derelict buildings. And that's something that really concerns us. We really value the communities that we work within, and we're really hoping that continued conversations could be had if this proposal goes forward about what happens to both the building at Page Hall and the building at Burngreave. And I know the same will be for other practices around the area, and I just really value the input from the committee about that kind of concern. So thanks.
Thank you. That was a concern that was raised when we met a couple of weeks ago, actually, about the future of any vacated buildings. Not quite sure really whose responsibility it falls under to, you know, to oversee that. But I mean, I assume that is, you know, one of the objectives in the whole programme, Jackie. Will there be a working group established?
Yeah, thank you. Absolutely. I think we're all coming to this from the same place. Nobody wants to see derelict buildings, empty buildings. We really want to work with everybody involved to make sure those buildings do end up with a meaningful future. There's a mix of ownership where we have buildings that are in ownership of existing partners. Perhaps we have a greater shared responsibility and ability to move forward. Where we have a building that is owned by a landlord, whilst we don't have perhaps the same relationship that we do with existing partners that own buildings, I think there is a shared aim there to make sure we maximise the potential of those buildings, because as a landlord, clearly they don't want an empty building stood there. So it's a complete loss to them if that happens. And I think working between ourselves with practices and with the council, I think having an idea of how we take that forward is in a sustainable way is really, really important.
Thank you. Mary?
Yeah, the council's currently doing a review of all its buildings across the city. You know, there's I can't remember how many there are, but there's lots, and sustaining them is financially very difficult, and maintaining them, and there's a massive maintenance bill. I'm just aware in Burngreave that there were a number of community groups that got hold of buildings some years back, and some of those then become unsustainable. And I wouldn't like to see a building that is particularly, I'm saying Burngreave because I'm just aware of this. It's not my area, so I hope I'm not treading on other councillors' toes. That you have a building that's then taken over by a group that can't keep it going, and it becomes derelict just because it's just impossible to sustain financially and otherwise. So just be very, very careful about how you dispose of those buildings.
I think we absolutely recognise the point, and it is one of the key things we need to work on. It's difficult to give commitments today, but it will be one of the parameters that we're looking to take forward.
Thanks, George.
Thank you, Chair, and thanks for this. And yeah, it's been good to review this over a few days because it's quite a long document. Look, I'm not a normal member of this committee, and it's been considered many times in so many different ways, and I don't want to do is get into things that have been gone through many times before. I suppose one very quick comment on the buildings. I just think one extra thing to consider is just that unfortunately, being the time of finding different uses for these existing buildings at one of the most difficult economic times to do so, and often in parts of the city where there is already struggles. So I just think, I think we all here want to underline that, the importance of doing that, because it might seem in many people's minds to undermine a positive result of a new building if people are seeing potentially closer to them that existing building in a poor state. And I know the question will be asked to many people, oh, well, why couldn't they just keep my old building open if it's just empty? So the quicker we can deal with that, the better. My other point is this, and it's not new. The point about transport, in terms of the consultation, what term is here, the points in the consultation that you've seen, that the decision-making business case assesses whether you feel that they can be answered, and whether they're green or in red or whatever. It's those conversations with what is now the Mayor's Transport Team, formerly SYPTE. I just want to say I've had conversations with them recently, completely different things, but buses in my ward, which has been quite a difficult issue, and they're very proactive, and I'm sure you've had really good conversations with them, and that's been laid out. But I just have to express a real concern about their ability to really change things, not just now, and I really hope that we can change it to a few years' time being a positive trend in terms of moving things, even just moving bus stops or changing services. But unfortunately, we have to see that right here, right now, we're on a negative trajectory there. And so I suppose the clearest thing I can say is I feel that we should be looking at making that assessment on transport and public transport particularly based on not the worst case scenario, but but the potential that things could worsen. And to be honest, things could worsen getting people to their existing surgeries as well. I'm not suggesting that. But when in general the distances, as the report lays out, are longer, even though they might be only moderate. But there will certainly be, but they certainly might be new routes to people. I just think there needs to be consideration, particularly of the viability, therefore, of some of the other things talked about, where the assessment of minibuses or other things. And for me, I'm not very well cited on whether that is simply an assessment with no potential funds or plan to make that work if necessary. Are we simply assessing it and say, well, we're going to assess it, that's fine, or is there a potential for a plan to make that happen? And then just the last thing I would say, I think is worth noting, because it's the substantially new part here, is I think that, to my reading and to most people's straightforward reading, it feels like the right process has happened to match the increased cost, which we understand, with the removal of that Concord site. In terms of the fundamental analysis of most things, including accessibility and the cost of the building, against that, my view of reading this and assessing this from the scrutiny point of view is that would seem to be the sensible decision, given the cost. Clearly regressible in terms of the cost that are faced, and that's aside from any other analysis of the scheme overall. I would comment that for me that feels like the sensible decision made there. The only one of those hubs that you could drop with such compelling reasons of doing so based on the consultation and other analysis. I'll leave it there. Thank you.
So, I think absolutely acknowledge that transport generally is an issue, and we're not going to solve that. I think in terms of if we go ahead with the proposals as recommended, what we need to do is a more detailed practice by practice assessment in terms of implications. So Alice might have quite different issues in terms of Page Hall relocating because of the proximity to the existing surgery, and similar for Sheffield Medical Centre, whereas some of the other practices will know the impact on their patients more acutely. So I think the proposal is that we move on a practice by practice basis and work with the practices to assess how they might mitigate some of those impacts. I think we're not going to solve bus routes per se. We have got commitment from the Combined Mayoral Authority that if we demonstrate that there is demand and they could relocate existing routes, they'd be absolutely prepared to work with us. But we need to demonstrate that there is that demand for using those bus routes in order to do so. And then how we might look at alternative proposals. You'll recall people that were at the previous meeting that Dr. Meeks, who came, was talking about how they might choose to look at their patient list and the impact of that. So I think we need to be careful not to assume that we have the kind of solution today, because I don't think we can do that, but we absolutely have made a commitment that we will look at that with practices. In terms of practically, we have said that there is potential for revenue savings to be freed up from these schemes, and that they would be reinvested in the local area. So one option of funding would be to use that. It would mean we won't use that funding for something else. So there will be options that we need to make and trade-offs. So would it be better to be used to recruit additional staff? Would it be better to pay for a minibus route? In that, we have to put forward different proposals. So I think this is a stage where we need to make a decision on what we go forward with, but we won't have all the answers. The point at which we make that decision to start putting spades in the ground and building is the point at which we'll have had all the considerations. Mike, I don't know if there's anything from your discussions.
Thank you, Jackie. Just a couple of points. Absolutely understand the point made around bus routes, and I think the diversion of a route is far more feasible than providing additional routes, and understanding the needs of patients by practice. I think that's really important. I think the point around how we've come to the conclusion of sample one, why that's the recommendation that we're making, it isn't just around affordability, it's absolutely all of the measures that we've set out. I would agree it's a sensible conclusion, it's the most logical conclusion, but even if we didn't have the affordability issue, I think it's still the conclusion we would come to.
I'd just like to make a comment on this issue that, Jackie, you mentioned that you'll have to demonstrate demand for bus services, but I think to put the boot on the other foot there, we're already at a point where a lot of people have given up on the bus services, so you can't just look at what current demand is and what current usage is as a measure of what real aspiration would be to use those buses. So if we had the world-class services that we'd once had in Sheffield, demand would undoubtedly be a lot higher. So I think you have to be a bit careful in measuring that demand. You know, we've heard anecdotally of patients who are putting off appointments or missing appointments, or not bothering to make an appointment because they just find it too difficult to negotiate the public transport system and they can't afford a taxi. These are comments we've made before. So just because there aren't many people who have said, who have commented about the bus, doesn't mean that there isn't more demand hidden away there. So I think is one that needs looking at very intelligently, if you know what I mean, which I'm sure you will. Any further questions, colleagues? Kevin?
Alice, I've sat here quite a few times now, listening to the reports on this scheme, and all the way through the various GPs that have come to this committee have been totally in favour of this in terms of the outcomes and the impact that will have on your patients. You're the first person to raise some doubts, and those doubts being affordability. I just wondered if you could expand that, because that seems to be a bit of a bolt out of the blue, that all of a sudden one of the practices is having the doubts about this.
Thanks. Yeah, I'm really happy to, and this is something we have talked about quite widely in multiple meetings, so it's something that you're very, very aware of. I think it's really important to say that as a practice, and I had communication yesterday with the practice manager and the partners, we are positive about this, and we do think this is the right thing. It's the right thing for lots of reasons. You know, we are Pagehill's a wonderful area. It's hugely culturally, diverse and with an amazing population, but huge deprivation. It's an area that needs investment, and it's got really significant health inequalities. What I didn't say is that one of my roles is I'm the health inequalities lead for our Foundries Network, so it's something I'm really very kind of passionate about. We need sustainable quality general practice in the area, and actually this is part of the solution to that. I know Dr. Meeks talked before about the fact that recruiting partners currently in our current climate is really, really difficult. And one of the issues around that is ownership of buildings. And, it is not favourable to salaried GPs to move into partnership, because actually take on the personal risk of a building. And often a building, if you're choosing to work in areas of deprivation, they're buildings that are not worth a lot of money. And that is not great. Having said that, I think we always have to be mindful that there is another side to this. And the other side to this at the moment for Pagehall is this issue about the fact that, our practice as it is works really hard. It's financially stable, but we are worried. And I think the ongoing discussion, and in fact, we're getting positive feedback from Mike and the team that there is a solution there to be had in this, and that actually we are not going to be financially out of pocket and having to make cuts to the service we provide in order to afford to be in a new building. But we haven't yet seen that laid down in figures, because we're not yet at that stage. And so I think we just have to be that there are trade-offs across the board in this, aren't there? But I think our feeling is it is the right thing. I would love our patients to be able to come into a new building where the accessibility is there, where we've considered the disability access, where we've really considered how we can provide the best healthcare to our population. The other thing that I know has been talked about that we're excited about is the fact that, we just haven't got enough space. We're absolutely splitting at the seams. You know, I walk up and down the corridor sometimes trying to find the right room to be in that day, and there's always one, but it's working out which one it's going to be, because we have got so much going on in our building, and we would like to do more. And so that for us is exciting. So yes, the financial stuff is a worry to us, and we think that it's going to sort itself out, but we haven't seen it written down, but that's the big thing for us. But we do think this is a positive way forward, and we think it is the right thing.
Can I just come in on that and just give a bit more of the sort of illumination on the discussions that we are having with all practices and have done from the very outset. So we knew fundamentally that if this was going to be a significant cost to practices moving in, they would not be able to move forward. So it has been one of the foundations of the scheme from the very early discussions. There's a lot of complexity within that. What we have done is modelled that as starting that in the draft outline business case to the next stage. But we are sticking to that principle that this must not cost practices more than they do at the moment. And the way that we're able to do that is to stay within the resources that we have. Is at the moment we pay rent, predominantly rent, to practices for their old buildings. Moving into the new building in public ownership of the council as proposed, it would be rent free. There is a service charge. That service charge will be higher, or the cost would be higher because the buildings are bigger, they'll need more cleaning, they'll have facilities that we just don't have within existing practices at the moment. So they are more complex, it will cost more. But equally, a lot of the costs that practices are seeing now in terms of energy cost, 4 or 5 times what we were paying in 2019, that is a direct cost on practices, a very real pressure at the moment. And our aim is for these new buildings to be net zero carbon, to have a high level of on-site solar panels generation, very low energy requirements and very low energy bills, and that helps offset some of those costs. So we have got a model that we believe we can sustain our offer to practices of this not costing them more, but still releasing some savings that we pay rent on old buildings. If that's helpful.
Thank you. Anybody else? Martin?
Just another small comment. Thank you for the report, and thank you for taking into consideration the feedback around SAPL 1. It's good to see that being listened to. Just around City, I note that on the report it noted high stakeholder approval. I'm a City Ward Councillor, so I guess I'm wearing that particular hat on this. While that's probably true, and there is probably a lot of support for that, I just question how that's kind of been measured, because in the pre-consultation case before City was kind of delayed, there was really low feedback from City, so I just kind of wanted to make that point that we can't judge that in a way yet, and I just wanted to put the point across that hopefully when the proposal finds somewhere, that we make an extra effort to make sure we do get responses from that, because I think out of everywhere that had the lowest response by quite some way.
Yes, I think you're right about that from the pre-consultation, and obviously that's why we're committed to doing the consultation once we've identified the site. And you're right, we will have to consider carefully the methods and approaches we use to engage with the population in City, because it is such a disparate population with a wide range of different. There's such a wide range of different population cohorts there that we need to make sure we're hearing from all of them. So we're committed to doing that when we find somewhere to when we confirm a site.
And I think just to note the assessment in the document that's presented is based on feedback from stakeholders that we've had to date. So it isn't the full statistical analysis, but we have had positive soundings from the stakeholders we've engaged to date.
Thank you. I have a couple of questions myself. I've sort of asked this before, so apologies for going back over possibly the same ground. How will the performance of these new hubs be evaluated over time? I'm wondering how and when there might be a performance framework determined to measure success over short, medium, long term. and what those measures of success might look like. So we've read over various reports that we've received. We've read about the objectives, and I think we all understand the objectives. But how will that be monitored over time? Will there be kind of a baseline set down at the point of transition that might record the number of patients per GP full-time equivalent, to set that as a baseline, because we've got a growing population to consider as well, which I do know is covered in the report. Might there be some kind of analysis of current access to primary care appointments? That's a comment that's come forward from so many patient stakeholders, waiting times and actually being able to access appointments. Are we putting down a baseline here to measure from, to see what the success of these new hubs is, anticipating that some of the workforce problems might be solved and there might be greater capacity over time?
It's a really interesting question, and it is very complex to measure the success of this project. I think probably the first thing to go back to is what Jackie said at the very beginning of this, which is that the buildings in and of themselves are enablers that, to release other opportunities. So actually what we are interested in measuring is the success of the whole programme, which is about how we can transform primary care. And what we will need to set for ourselves, what we have to decide upon is the outcome measures for that, and also how we can distinguish, because obviously achieving those is multifactorial, and it may be that specifically in terms of having the hubs, what we are looking at is affordability for practices, and we're looking at cost versus previous costs. We're looking at whether recruitment has improved, and then whether that supports and releases some of the other transformation opportunities. So how well that PCN is then able to leverage that space to deliver some of their transformational outcomes. So some of that will be measured through the objectives that the practices and the networks have already, and we can compare that, if you like, with networks that don't yet have those opportunities, that they're our control group to a certain extent. So we can see whether this is whether these developments have helped either initiate or expedite some of those plans. In and of themselves, I think looking at simple measures such as more obvious measures such as access and access times aren't necessarily helpful, because there's so much else happening in the system. But we will want to look at that in the round, because this isn't about performance managing practices who move into those buildings, but it is about measuring whether it does release those opportunities for the practice. So does moving into that building give the practice more space so they can either recruit or bring staff in, and therefore increase their capacity, increase the opportunities in their appointment book? And do we see that improvement coming through in terms of patient feedback, patient access, quality of patient experience?
I think, sorry, just to add, I think you raised a really important point, and I think what we need to do is set out an evaluation framework that looks at the objectives and how we might measure some of that. So yeah. I'm happy that we can take that forward as an agreed recommendation. I think Abby's right, we are dealing with complexity, but equally we need to understand the lessons that we can learn and how that might be spread out more widely, because a lot of the issues that we've highlighted for the areas we're looking at the moment aren't unique to these areas. So there is something about how we can translate some of the benefits, but knowing that the injection of capital is unlikely to happen again. This is a fairly unique opportunity we have at the moment. So we do need to think how we support practices elsewhere with some of the things that we're testing out here.
So there's thinking about how we translate that. And within the South Yorkshire programme, there is an evaluation framework as well for the programme as a whole, so we can fit into that. So I'm happy to take that forward.
And in terms of that work that Jackie's just described, this programme fits or aligns closely with one of our other aspirations for primary care, which is around building a community of practice. So support a forum or a way that practices can come together, or interested staff in practices can come together with both peer support and facilitation to start some of those transformation programs and those transformation journeys, and how we give them the space and the support to enable them to do that, and also how we take the learning from that and share it with other practices. So it fits into that and fits very closely with that as a vehicle for sharing that learning.
Thanks. I do think it's important to put down some kind of baseline of what the starting point is, especially in view of the report that we requested to the last meeting of this committee on the state of primary care in Sheffield, and what we heard about waiting times and access to appointments. I think it's quite a good point in time to kind of put that down and measure progress from there. I'd be really interested to look at that over time. I think as well, if it is found over time that access to appointments, when I say access to appointments, it's really, I think what you're really measuring is, are patients seen in an appropriate and timely way? It's not just as simple as, did they get an appointment? Is it because, and we're talking about all sorts of complementary services and wraparound care that will hopefully be co-located in these health centres. So it's not necessarily that someone saw their GP, is it? It's access to the right kind of care at the right time. And if it's found over time that that is not improving for patients within these new hub catchments, what would be done then to pursue a way of rectifying that?
Yeah, I think you're right, and a lot of that is about not only the experience of the practices and the other services, but the patient-reported experience, and making sure that we capture that in a way in more depth and in a more comprehensive way than is provided for at the moment. But you're right, it's not just about simply, you know, can I get a face-to-face appointment with my GP? Because part of the purpose of this is finding those different ways of working and making sure that they benefit you know, that they benefit patients. So I think what you're describing in terms of where do we set our expectation in terms of what the benefits these developments will deliver? How do we measure that, or what are the proxy measures for that? And then what do we do if we're not seeing that bear fruit in the way we expected? As we've said, that there's a bigger programme here which is about transformation, and that's ongoing. So it will be about, you know, what support do we need to provide to those PCNs, or what development needs are they describing that we need to sort of work with them so that they can realise those aspirations if they're not achieving what they hoped to achieve. If that makes sense.
Thanks. Mary?
So just in terms of the transformation that you want to achieve, so you know, a quantitative measure would be how many people are accessing services that they would normally go to hospital for and are now coming. So that's a very simple measure, isn't it? And you would expect, that's what we would expect to see, that was reduced, hospital visits reduced. So obviously that's travel time and you know, all the difficulties entailed in going to a hospital visit, and it would be a more local practice, I guess. But then there's the other the things it's more difficult to. You talked about peer GPs collaborating on all sorts of clinical issues and problems that you come across in your practices that you want to deal with properly, more effective.
I think, yeah, what you're describing is both the sort of quantitative and the qualitative measures. we need to be aware. I don't want to disappear down the rabbit hole of how easy or not it is to measure those things or how you would set them. But the example you've given about more people getting care in general practice or fewer people going to hospital, yes, it's about the services or the range of services that are accessible in practice, but simply measuring how many people are being seen in different settings isn't necessarily helpful, because as you know, what we're seeing at the moment is a huge increase in need and demand for healthcare services across the board. And what we don't yet know, I think, is whether we will start to see that, how much of that is a product of the last few years and COVID, and will settle down to sort of more usual historic levels, and how much it will continue to increase. So you have to be mindful that the benefit that you're seeing might be hidden by other things. So those are the kind of factors we have to bear in mind when we're doing that modelling and setting those expectations for ourselves in terms of how we evaluate this. But I agree completely. Some of those we need to be setting both sort of qualitative and quantitative measures. And it's about staff experience, it's about patient experience, it is about the breadth and quality of services people can access, and how sustainable GP practices feel they are after this.
I think it's a really interesting question, and I don't know that I've put a lot of thought into this, and I know that this is certainly something that you'll be thinking about more. It's something that is hugely complex, and the increasing need for general practice appointments in their widest sense has got loads of drivers, and that's the thing that worries me, is that the buildings are part of a package which will hopefully create sustainable general practice in these areas where there is, all the areas we're talking about have got significant health inequalities. But the drivers are about increasing health inequalities, they're about an ageing population, and they're not things that the buildings are going to solve. So I think we just have to be a little bit careful about what measures we put in place, and we don't want a situation where we're trying to chase a target and chasing a target, in doing that we're offering worse care because we're chasing a target. So I think we have to be really interesting and probably quite creative about what measures are used to really find out and understand the kind of success of this project. Yeah, thanks.
And I think, and obviously this is something that we would do both, what we would want to do with this is co-produce it both with the practices and networks and also the local population. I think it's really important that we ask people what matters to them, and use that to inform how we set our success measures for this programme.
Thank you. I've got a sort of curious question. You've sort of touched on it earlier on in mentioning that this might be a model to use in other parts of the city, and with the caveat that you're not anticipating any extra funding of this type coming forward again, although you never know, governments come and go. Are there any other areas of Sheffield where similar problems exist in primary care that you've already identified? And if there were future funding streams that could be drawn upon, have you already got areas in mind that might benefit from a similar kind of transformation? If there aren't forthcoming funding streams, what do you think the ICB could do or should be doing to ensure that the case is made proactively to NHS England that we might need this kind of transformation elsewhere in the city?
Thank you. If I can pick that one up. There is a piece of work underway currently looking at primary care network estates plans. So without concluding that piece of work, it'd be wrong to point which areas are most likely, but we know the factors that feed into demand for primary care and matching that against the resources that we have. So we have developed a primary care dashboard, and we're starting to examine that, but also working with practices in each of the primary care networks, 15 networks across Sheffield, to develop a plan that's got a plan for every building. And some of that is about making adjustments to, if a building's fine and doesn't need anything, that's great, or do we need to make adjustments, or is it a relocation, or is it moving up to a transformational scheme? And that's looking at how we can deliver on the wider needs, not just about estates needs. for future primary care. So I think that's something you'll probably be hearing about more in the future, but that's an active piece of work. And we'll be exploring other funding routes, not just about central government funding there, whether we can actually generate that from other resources as well.
Just to add one point, so one of the interesting points of learning through going through the development of these proposals has been to work with healthcare planners, and that has identified, even with existing practices, there are different ways of utilising the building, of organising things. So I think we're going to have to be quite creative, because we know there are immense pressures, as we've described, in terms of general practice. So if there isn't a gift of funding coming from on high, we still have problems that we're going to have to find solutions for. So that's what I was referring to in terms of trying to understand some of the learning and some of the things that we've gone through. Abby talked when she presented at the last meeting around some of the work to take some of the space that's currently being used for notes and using that space differently. So we are trying in all these when problems arise to anticipate that, and as Mike said, in a more systematic way, going through on a primary care network by primary care network, looking at where spaces might be in different buildings, and you know, and need to admit, in lift buildings, which are, we have the problem of being very expensive, we have got space, but it's about how we utilise across the totality of resources. So yeah, it is a work in progress. Mention Baton.
Yeah, so Baton is one of the areas that we're actively working on at the moment, with the former Baton Health Centre. It's been vacant for a number of years since a practice relocation, and we're developing quite innovative proposals there to bring that back into use as part of the network plan for Townships 1 and 2. So there's an example there of how we can use some of our existing assets better, and as Jackie says, the void that we have and underused space within our lift buildings, making sure we do maximise what we have before we build new buildings.
I'm glad you mentioned Baton. What is stalling that at the moment?
I think it's actually trying to be quite innovative and looking at how we make the building sustainable without just throwing money at it. I think there's some really good work between the practices and with community groups. We're working with the Baton Village Development Trust there, and I think we're very close to getting that concluded. It has been quite complex just around the funding agreements, but we are putting in some support to that and making sure that it's best aimed at the needs. I think the key thing there is not just about opening the building, but making sure it's well used over its full day.
Thank you. I've got a sort of procedural question. I noted that the Strategy and Resources Committee, which is the council body that will make the decision as to whether or not the council is happy to go ahead with these plans for its part, that committee was due to receive a report at its meeting this week on the 5th of December, and there was no report, so the item was deferred to a special meeting on the 12th of December. I just wanted some clarification as to how that occurred, how it got delayed, and ask how, it's a sort of practical question really, because of, we've received a couple of very large reports to this committee. I think three times from my own experience, I've been up late at night reading very big reports on this particular item, and just really how much in advance of their meeting will the members of Strategy and Resources actually be able to access a report? Are they really going to be fully appraised and have time for a briefing if they need it before that meeting? It's just a matter of concern, because I know how difficult it's been for members of this committee to appraise the volume of information that we've been given, and we've followed it all the way through, but there may be members of Strategy and Resources who've not been following it quite as closely. So will there be an opportunity for briefing for those members well in advance of the meeting? We've got Joe Horrobin here. I'll bring you in, Joe.
Yes, happy to take that question. The rationale for moving the paper from this Monday's Strategy and Resources Committee to next week was in order to ensure that there was as much time as possible for members of that committee to review what is a substantial amount of information. The report itself, from an officer's perspective, making the recommendations to the committee, is not an extensive report. However, the number of background papers, including all of the scrutiny notes and responses, make it pretty thick, yes. The paper should be published, I'm hoping, today, and that has been a procedural challenge because we've had to wait for the decision on Monday to defer the paper formally before we can publish the paper ahead of the committee on the 12th. So I'm hoping and expecting that we will be able to publish the paper today, which will allow members of that committee to have, what day are we on? So yeah, three working days to look at that. It's not ideal, however, we have had to follow the procedure set out by our democratic services and agreements.
Thanks, Jo. Was there anything else to comment on that? No? Okay, thanks. Are members happy that you've understood what's happening at that end of proceedings? Yeah. Yes, Jo.
Sorry, I just wanted to add that one of the reasons that, a key reason that the decision was made to defer on Monday's committee was because we had been taking the time to take on board the work done by our ICB colleagues and to take on board the written response that came from Scrutiny the previous week. So we have been trying to make sure that we have triangulated and cross-referenced all of that in order to put a fully informed recommendation to Strategy and Resources. So that was the reason why we didn't want to bring it with not enough time for due consideration on Monday this week.
Thanks for that. That's great. Are there any other questions or comments from members? I'd like to make just a sort of, by way of trying to sum up a little bit the discussions we've had over time with this. I'm not sure whether we're going to reach a conclusion as to our whole formal response today, but if members can just have a think about what you might want to put into that response. If there's anything you want noted today, then please mention that today. But we have got space, as we did after our last meeting, to collate our responses with a bit more breathing space to do that after this meeting by the 14th of December. I would like to make just a sort of general comment, really, in addition to all the very detailed comments and queries that have been raised by members of this Scrutiny Committee and its predecessor, in fact, before last May, as they've examined these proposals. And my observations are, I think that councillors are not necessarily happy as such with the notion of losing practices from their current locations, and that was always going to be a sticky issue, and that really a kind of best of all possible worlds outcome might have been achievable if there'd been greater and more flexible funding offered by the government, but then we'll never know really what could have been the outcome if that had been the case. So as things are, I think members of this committee are probably under no illusions that the programme is any kind of silver bullet to fix primary care in Sheffield. But responsibility for that, I guess, in the end, and addressing the chronic problems of workforce and infrastructure and waiting times that we hear about so frequently, that ultimately lies in Westminster, not so much locally. So I think it's probably fair to say there's quite an element of compromise in the whole scheme, and that's what has to be worked with and what has to be made the best of, really. And I think I feel quite satisfied that that's the process that's been undertaken, and it's been extremely thorough. and really trying to achieve an outcome that balances the needs of those who deliver primary care and those who receive it. With all that said, I really sincerely hope that if these new hubs do become a reality, that patients will really quickly start to feel the benefits of access to more frontline services in one place, and that the practitioners who are busting a gut, quite frankly, to deliver that will also start to feel the benefits very quickly. So I think that's where I'm at with it, and I really want to hear members' comments to feed into our response on this stage of the proceedings. If anyone wants to comment now, please go ahead, and as I say, there's plenty of space after the meeting as well. Trish?
I'm not going to reveal my age, but I was a GP in Pittsmore when the patients were sitting on the stairs. We had no waiting room. We had no practice manager. We had no practice nurse. We just had the one receptionist and paper notes. And general practice has completely changed since then. And it is still changing, and it needs to. And we've got to try and support that change. Unfortunately, the patients loved my partners, the elderly gentleman who I joined in practice. And it was wonderful. They were their GP, and it was very much a family business. It's changed. It's now a health service. And we have to support them that they're trying to do this health service. And it's awful having patients sitting on stairs waiting for you, and no appointment system and only one phone. It was not really medicine. It was looking after nice neighbours. But general practice now is such a different job and such a different business that I'm proud that Sheffield is supporting these practices, and I think the patients will actually benefit from being able to go to nice, bright, warm places.
Thank you. Thank you, Trish. Any other comments?
Can we get a bit political about this? I just think, GPs do a fantastic job, and everybody in a primary care setting does a fantastic job, despite the government and the shortfalls of this government. And I think, what you're trying to achieve is absolutely, you want to go in the right direction. It is the right direction. There's lots of hitches and lots of people saying, well, there's this problem, that problem. And there are problems there for people and individuals. But if you can transform that primary care, that's just what your aim is, and make it what your vision is of that. I think that's good, and we can all learn from that. I'm sure you can generalise that across the city. Hopefully, you can do in time.
Thank you, Mary. If there's nothing further, I think what I'm going to recommend is that members have the chance to write some comments down, things that you feel are important to feed in at this stage. We could try to convene a meeting where there's been a lot of meetings for members of this subcommittee. So if it's easier to do it by written submission, that might perhaps be a bit kinder on all our diaries. Would that be an acceptable way forward? Members, yep. So if we can go ahead and collate our responses in that way. So the formal part, the subcommittee can agree its response during the meeting, which we're not going to fully do now. If it needs further time to do this, what we need to agree to is to delegate the development and submission of the formal response to the NHS to the Director of Legal and Governance in consultation with the Chair. And the Chair, I will assure you, will be in consultation with all of you. Are we all agreed on that course of action? Thank you very much. And thank you all once again for attending. It's been a huge amount of everyone's time just this year. I'm aware, many meetings and a lot of questioning. So thank you very much once again. Okay, so item 9 on our agenda is the work programme. I'm going to ask Emily if she has anything to bring to our attention on the work programme. Sorry, Emily, I'm rushing you.
Thank you. So the work programme is set out, including the additions that you made at the last meeting of the committee a couple of weeks ago. There was the addition of the looking at mental health treatments and interventions for people who don't reach that clinical threshold, and the CQC inspection of CAMS from the Children's Hospital, so they'll be coming in January, and then from today we'll add on Firshill Rise coming back, and the change programme, and also the learning from Firshill Rise to come to a future meeting. And then it's just asking you to, any comments, additions, and then asking you to agree the work programme as set out in that appendix.
Are there any comments on the work programme or anything that any members would like to consider adding to that? Martin?
Just for consideration, I wonder at some point, not necessarily a specific meeting, we might want to consider how the NHS and how our health systems are addressing the findings in the Race Equality Commission report. So I don't think we currently have an item for a set meeting on that, so maybe it would be something we could put on to find a meeting at some point, if that sounds agreeable to the committee. We could discuss this later out of the committee as well. I just thought I'd raise it.
Yeah, thank you. I'm just going to look at George. Are we taking an item on that through the Adults Health and Social Care Committee?
Sorry, Chair, there's so many items. We might just want to recap. It's probably worth having an informal discussion afterwards, and then working out whether that's going, because it might come in a slightly different form. But yeah, so can we have an informal discussion so we can work out where it might be on the work programme, and then see if it's appropriate to come here as well.
Yeah, thanks. I think if there is anything going through the adults and in fact children's committees, that would form a part of, I think, what you're talking about, Martin, possibly, that you're wanting to query NHS South Yorkshire and Sheffield Place about that.
Yeah, because the findings weren't just specific to Sheffield Council, to my understanding, so it'd be good to see how the NHS are looking to address that. I think the update report came to the Strategy and Resources Committee as an overview this Monday, but committees have also looked independently at how they're addressing it within their portfolios, so it might be good for us to consider. Yeah, very happy to discuss informally.
Yeah, that would be good if we can have a discussion about that outside of this meeting. Okay, I'm advised there's nothing currently on the Adult Health and Social Care Work Programme, so that's something we'll pick up in discussion then, Martin, if that's all right. I've got a suggestion following our last meeting where we heard a report from the ICB on primary care. I wonder whether we could use the workshop options open to the committee to hear more from practitioners in Sheffield. Maybe if we could approach the local medical committee and primary care Sheffield and representative GPs from some of the PCNs, and maybe pull together a sort of workshop or evidence hearing session just to help us understand a bit more about what's happening from practitioners' point of view. Anything else? Okay. Are we agreed to accept the work programme as it is, bearing in mind the discussion we've just had as well? Yep, thank you. And I think that brings us to the end of the meeting. Thank you very much indeed for your time. Members will try not to meet every single month, but thank you very much for today.